So the new Matrix movie came out. Have you seen it?
I have not seen
The fourth one. Have you seen any of the other ones?
No.
Yeah, I heard it was kind of like, it like makes fun of itself a little bit. You know how I know we're not in a simulation?
How's that?
I think that a computer would not mess my life up this bad. I've never seen a computer make so many mistakes if this is a simulation. So. All right, well, hello and welcome. This is Guardian Back to Basics podcast. I am Jason Seitz. I'm a firefighter, paramedic, a nurse. I don't know what I want to be when I grow up. And usually I'm here with my brother, Chris, who's an ER physician. But today we have a guest, Chris. Not a guest star because, one, my brother is never a star. And this guy's also named Chris. So this is Chris. He's a very good friend of mine. We grew up together, Chris Perrin, and he is an athletic trainer. And he's going to be our resident expert as today we talk about sports injuries. Before we get into it, we're going to do some announcements real quick. For one, if you don't know about Guardian Test Prep, you should. That's the whole point of this podcast, to tell you about Guardian Test Prep. So check it out, www.guardiantestprep.com. We offer a full program to prepare you for your NREMT, whether it's EMT, paramedic, advanced EMT, whatever you need. It's got 15 hours of videos. It's got great questions. It's got access to me and my brother to help you out as you're studying. It's great for when you're in the program, and it's great for when you're about to take your test, because that is a tough test to kick. So besides that, this episode will be airing on Guardian CME in about a month. We offer a free CME credit if you're a provider already for listening to the podcast. You just got to listen to it on the site, take a quick quiz, and you can get a CAPC credit, which means that that's a universal credit. You can get that anywhere. So check that out. Other than that, no crazy announcements. Let's jump right into it. Since you're new to the show,
yes.
Welcome to the show.
Appreciate it. Happy to be here.
Let's just talk a little bit about like introduction, background of like who you are, how you know me. So why don't you tell the story of when we first met? Yeah.
Wow. Okay. Well, we met back in high school. You and I were not all that close initially, I would
Correct.
think. Yeah. And then we kind of grew our friendship over the years. And then we kind of ended up at Michigan State together.
Yeah.
Roommates. Went well. I think we enjoyed our time.
Yes, we did.
Went to classes.
Sometimes.
But had some fun outside of class. Did some longboarding. Had some injuries. Which was fun.
Talking about sports injuries. No, exactly. I like to say that Chris was like a very popular, cool. He was like we went to a very small high school. So there was only about, 35 people in our class?
Yeah,
in our graduating
35
class.
or 40,
really
something
small
like that.
private school. Chris was like the classic, cool, popular kid. And I did a very Jason tactic, and I just attached myself to Chris until he liked me. Like that was my progress to popularity was simply just being in the room with Chris all the time. And then it
worked out well.
Like most of my relationships, I gradually wore him down, and now he's my friend. So that's where we're at. It's great. So you are an athletic trainer.
Yes.
Why don't you tell me a little bit, because this concentrates more on EMTs, paramedics, nurses, doctors. Why don't you tell me a little bit about what an athletic trainer does and kind of the background in like how you got into that?
Okay. So athletic training obviously is sports related mostly. You can do athletic training in other settings as well. But the main keys for athletic training are prevention, evaluation, and then you kind of do the treatment and recovery process after injuries. My background, I went to school, Michigan State, did my undergrad there. They have a pretty well-known program. You kind of get into their program and then get put through various sports to kind of test the waters and see what you like. After I graduated Michigan State, I went and did a graduate assistantship at Detroit Mercy, where I worked women's soccer and then kind of got my master's in health service administration, which is a little bit different than kind of the athletic training route, more the admin role, actually more hospital setting, clinic setting, than sports setting. And then after I got my master's, I was actually hired on at Detroit Mercy with men's basketball, where I worked for 4 years there before moving to my current position at the University of Missouri with men's basketball.
That's awesome. So mostly you're a basketball guy. I know that you played basketball.
Yes.
That's your sport of choice. But you did women's soccer.
Yep.
Didn't you do tennis for a little bit too?
Yeah, I was in charge of men's and women's tennis and men's and women's golf at Detroit.
Yeah, you were all over the place. Cool. And then in school, do they have you just they rotate you around, if I remember. They rotate you around different sports like throughout your school.
Every half semester, whatever, you get put with a different
With
sport.
a master's degree, how many years total was it for your education?
6.
Oh God,
6 fun years.
That's terrible.
Yep, wouldn't do it again.
Wouldn't do it again. Love the job. Wouldn't do it again. All right, cool. Well, that being said, what kind of similarities or differences do you see in like my job versus your job in terms of like paramedicine or emergency medicine and what you do?
Well, there's definitely the trauma situation. That's very similar. Each dealing with, just controlling trauma, wounds, whatever, bone breaks, all the, acute traumas, I think is very similar. Maybe some of the major differences are treatment, post-injury.
Yeah.
Like long-term treatment and recovery like process, and then kind of like the rehab piece, prevention.
Yeah, we don't get to prevent injuries. We just show up. So this is, Chris basically is a medic on the field. And then we take them to the hospital, and then they go back to Chris. We're kind of just a middleman in it. I don't really know why, but Chris is going to be the guy who runs out on the field and gets them, or the court, and gets them set and figured out. And then we take them back, and then we would kind of like transport from there if it was a true emergency, or you would deal with it on your own and not bug us, right?
If it's a true emergency, I hopefully would bug you.
We had the opportunity a little bit when we were younger. I would work as a field medic with Chris for like football games and soccer games and stuff like that. That was fun. We made some cash doing that. Was that a football game that we did?
What?
Yeah, remember I came with you and we drove around a little golf cart.
It was lacrosse.
Yeah, it was a lacrosse tournament. So I had done it for football before, but the lacrosse was with you. That was great. It was good money too. Did that. Yeah, if you're a medic out there and you need some cash, get hooked up with an athletic trainer because they get some sweet field medic positions and it pays pretty darn decent. So, all right, cool. So jobs are very similar in the sense of the acute injury. We're both responding to that injury probably together and getting them kind of packaged. And then if they need transport, then I take them. If they don't need transport, you take them. Either way, they're coming back to you for
most of the time.
Further treatment, rehab, and getting them back to good health. So we don't get to do a whole lot of that in the emergency field. So it's interesting to me to find out a little bit about like what happens next, how, or even on the prevention side, like, hey, how could this have been avoided?
Yeah.
So that we'll talk a little bit about that in a little bit. But first, I'm going to ask the questions that everyone's going to want to know. And one is going to be, what is the most common injury that you see?
Well, me being in basketball, the most common injury is definitely an ankle sprain.
Ankle sprain.
Yep. You expect a couple of them each year, no matter what.
Yeah.
And it's, obviously there's different grades to an ankle sprain, and different mechanisms of injury, but the most common ankle sprain is an inversion ankle sprain.
An inversion? What does that mean?
Inversion just basically means the bottom of your foot kind of rotates in, and you kind of are forced laterally over your ankle. So that lateral side of the ankle is injured.
So you snap in on you lean on the outside, your ankle goes on the inside.
Yes.
Okay. Yep. I was thinking inverted, like your ankle
flipping
is inside out.
That would be a medical emergency.
That would be pretty good. You definitely want to call me for that one.
Yeah.
And I would call someone like my brother because I wouldn't know what to do with that. Very cool. So what is the difference between, because we're talking about sports injuries today, that's what the CE is going to be on. What is the difference between a strain and a sprain?
Very, very easy, very different injuries. So sprain deals with ligaments.
What is a ligament?
What is a ligament? A ligament attaches bone to bone.
Okay.
So if we're dealing with the ankle, it's attaching one of the ankle bones to another bone in the joint.
Got it.
Protecting that joint space.
Got it.
A strain is a muscle injury.
Okay.
Very different than a ligament. So
it's like a tendon.
Tendon, muscle, yep. So any one of your muscles in your body.
Attaching to other muscle.
Attaches to tendon, which the tendon attaches to the bone.
Okay.
So it goes bone to
ligament
tendon
bone
to muscle.
Bone. Tendon is muscle to bone.
Muscle to tendon. Well, yes.
Okay, gotcha. All right. Tendon serves to move the bone or structure. A ligament is a fibrous connective tissue that attaches bone to bone and usually serves to hold structures together.
Correct.
That's the official definition. I wrote it down because I knew I was going to mess it up. So cool. So strains.
Muscles.
Sprains.
Ligaments. Sprains, usually joint space.
We care? So here's my final question is, do I care as a provider which one it is?
It depends where it is. It's going to tell you where it is.
All right.
If you're...
In terms of acute treatment, is it going to change anything?
Not necessarily.
Not necessarily. Is it going to change anything for you in terms of recovery or not really? Just location?
Yeah, a little bit with the rehab process, and just kind of the movements of what you're trying to do post-injury.
Okay. Is there one that's worse than the other, or they kind of just doesn't matter?
They're kind of just, strain, sprain, depending on, I mean, obviously like an ankle sprain, you need that with running, cutting, jumping, and basketball. So
yeah,
that might be a little bit tougher to deal with than maybe like a shoulder strain.
Okay. And it can be like, I'm sure there's different degrees. It can be like you could have like tears, or you could just have like the wearing down or inflammation of it. Like
correct.
What?
Yeah.
Okay.
Yep. In each, the strain and the sprain, they grade them in 3. So grade 1, 2, and 3.
Okay.
A grade 1 is just kind of like a stretching of either the muscle fibers or the ligament.
Okay.
So not too much damage per se. Grade 2, there is stretching, and there's also a little bit of tearing in either the muscle fibers or the ligament. And then grade 3 is just a complete tear.
Complete tear.
Everything's gone.
Oh gosh.
Just
so
tears,
surgery.
Surgery is definitely in the grade 3.
Okay.
Yep.
What is there a way to know what grade it is based on evaluation, or do you have to just get imaging done and you find out later? Oh my God.
You can pretty confidently tell with some testing. With the joint space, if we take like an ankle or a knee, and you're trying to test a ligament, you kind of force the ligament or force the joint against the ligament, which you can kind of test the laxity of that ligament.
Yeah.
With a grade 1, you're still going to have kind of that firm endpoint.
Yeah.
Might stretch a little bit, but you won't notice too much. Grade 2, you'll have a little bit of that opening of the joint space. Grade 3 is going to be pretty wide open. You're going to know.
And you can just feel that out through experience. Like they just kind of teach you to.
Yeah.
That's
I mean,
crazy,
it definitely
man.
takes experience and kind of a feel. And then, the more you do it, the more you kind of know what you're feeling.
Okay, second question I want to ask you is what everyone's going to wonder is, what's the worst thing you've ever seen? Because I get asked this as a paramedic all the time. It's like, what's the worst, most horrible thing you've ever seen?
Well, you've probably seen a lot of crazy things.
Yeah. I don't like talking about it. So if you don't want to talk about it, you don't have to.
No,
but like, what's the worst injury you've seen?
Like firsthand?
Or if you got something better that's not firsthand, sure. They just want to hear about the gory guts.
See, I don't know if I've seen a lot of gory guts.
Yeah, but like your injury, my injuries are like, oh, it looks yucky. Your injuries are like, wow, their life's ruined for the rest of their life. Like, have you had any paralysis or anything like that?
No paralysis.
That's good.
I haven't.
That's good.
I mean, maybe like the worst, and knock on wood, like I haven't had to deal with super crazy things, which is a good thing, but just kind of like blown out knees where knees. They're torn ligaments and meniscus and.
Okay. ACL tears?
Yeah, ACL.
Is that like the worst you can think of in terms of like on the court, if one of your players deals with an ACL, is that the worst?
Oh, no, I mean, on the court, the worst thing you deal is like,
like
cardiac
I
issues.
get that.
Or like break their neck.
Fair enough.
I would say those are worse than an ACL.
I got you. In terms of tearing things, sports injuries wise, I'm not going to count dying of a cardiac issue as a sport injury.
Issues.
There you go. I like it.
Yeah, ACL is probably one of the worst injuries that.
And ACL stands for anterior
cruciate ligament.
I knew that.
Yeah.
That's why I was just making sure you knew it. Good. And there's ACL, there's MCL.
Yep.
So medial. Same thing, but medial.
Inside of the knee.
There's LCL.
Lateral.
And then there's a PCL, you said?
There's a PCL, which is posterior.
Yep. So it's behind your knee.
Yep. So the ACL and the PCL kind of makes an X inside of your knee.
Okay.
Which kind of ACL stops the tibia from translating forward.
Okay.
PCL obviously the opposite.
So if I tore my ACL, how does that happen?
Usually very common in cutting, jumping, landing, and it's usually when your foot is planted on the ground and your body is trying to move in a direction that your leg is moving in a different direction.
Okay, gotcha.
Usually is like a pivot shift is what they call.
Okay.
So your knee is kind of shifting one way and your tibia is shifting another.
So it doesn't need to be, it's not necessarily a contact sport where you see a lot of those. It could happen in basketball all the time.
ACL is very common with a non-contact injury.
Yeah.
So it's just kind of your body not handling the force that you're putting on it.
And then MCL is the least minor. So here's my history of this is that last year in February, I went snowboarding.
Yep.
And like an idiot on the chairlift, got injured. The chairlift caught the back of my knee, so that it would have been I ride goofy, so I ride my right foot forward. The inside of my knee got caught by the chairlift. It pushed it, and I felt a pop. And then all of a sudden, I boarded for like 2 more hours, and then I called you because I couldn't walk to my car. So I ended up going right to your apartment, thinking, oh, I'll just see him sometime soon. And then it was like, no, I need to come over right now because I don't think I can walk. You had to help me into your apartment, and then you did some tests on me, and you were pretty sure it was an MCL at the time.
Yeah.
And you were like, no big deal. MCL is not a big deal. Why?
So the MCL is the only one of the 4 ligaments that will heal on its own. So it has, of the 4, it's the only one with a blood supply, which you need blood to heal. So that is why in most cases, it's a non-surgical repair, or
it'll heal itself.
Yeah, it'll just kind of heal itself.
Okay.
There are certain cases where if you do completely tear it, and you are maybe like a high-level athlete and you want to get back a little bit faster than just letting it heal, they'll do a little bit of like a surgical intervention. But most of those will heal on their own.
Okay. And then ACLs, LCLs, I guess PCLs don't happen too often, right?
PCLs rarely happen in athletics.
Okay.
What we're told is they're more like major trauma, like car accidents or
so something toward
like
not
that.
Necessarily like
there's a major
I got you.
force.
And then the LCL and the ACL just aren't very vascular. So because they have a low oxygen supply to them, they obviously take way longer to heal. And then often you need surgical intervention in order to expedite the process.
Yep.
Or to
they
get
won't,
healing
yeah,
done
they
in
won't
general.
heal on their own, so they need to be repaired.
That ended up being nothing, by the way. I'm fine. I know everyone's worried. I'm fine. It wasn't a tear. It was actually just a miraculous.
Yeah, I
believe you called me and said, I see your MRI results. I can't explain them because Jesus healed me. I don't know what to tell you.
It was awesome. Yeah.
Like 2 weeks later, I was walking fine. So
doesn't make any sense.
Spooky. It doesn't make any sense, but it was cool. Cool for me because I didn't have to pay for surgery and take off work a bunch. So, that's a little pro tip, guys. If you get injured at work. You don't want to get injured on the slopes.
And know an athletic trainer. To
hook you up. I like it. Cool. So we talked about grade 1, 2, and 3 injuries. There's also what's called a tibial spine avulsion ACL injury. Or you were talking earlier before the podcast about just
I guess they're
spine
common
avulsions in general.
Well, adolescence, I think we were talking about.
It's like when
it's basically what an avulsion fracture is anywhere in the body.
Just a disconnect,
which is just the either ligament or tendon pulling off the bone, which basically chips a piece of that bone off.
Okay.
Like it pulls it off with it, and that's what's an avulsion fracture.
So they've got to reattach that. At least for this tibial spine avulsion one, they got to reattach it.
In most major areas, they'll kind of reattach it. It can happen in, anywhere that something's attaching to the bone, it can happen. But in some cases, they won't do anything with it. It's just kind of heals.
Cool. Well, we've been over the one that happens the most often. We've been over the worst one, I guess, ACL, if we're talking orthopedic injuries for sports injuries. In terms of prevention, because we don't do anything about it, tell me a little bit about how you do taping, you do strength training, you do movements. Like how do you even figure out what kind of prevention to do?
Very basic prevention that pretty much every sports team across the country will be doing is just taping, ankle taping, which prevents, well, not necessarily prevents, but lessens if you do sprain an ankle, it kind of gives you a little bit of support.
Okay.
Stretching is prevention for, muscle strains. Weightlifting, that sort of training, learning how to jump properly, land properly, all of that stuff is kind of the basic prevention. If we do identify a weakness in some sort of athlete, whether it's weak ankles or their gait isn't as strong as it should be or proper as it should be, we kind of will add some prevention rehab exercises to kind of strengthen those weaknesses.
Cool. So you know a lot about the patient history, obviously, and that makes you a big resource to us if we're ever on the field or court.
Yeah,
we talk to you about like, hey, what does this guy deal with usually?
Yeah, we have to know kind of everything about the athlete when they come in, whether it's allergies or predetermined history of whatever it may be, or injuries in the past, whatever it is. We have to know those things and have those things on file. So if something ever does happen.
And then you kind of make a plan around that issue. I got an issue with my shoulder. We're going to work on my shoulder all the time.
Yep.
So with that, in terms of immediate treatment, I'm just going to go over with you what EMTs and paramedics are taught when it comes to acute injury when we're talking about orthopedic. All right. You just tell me if we're on the right track or if we need to rethink the education. I don't know if I'm that source, but... So here's the thing, and I say this all the time in my first aid classes, is when it comes to like first aid, like true, like responding to traumas is basically like a basic first aid thing. There's not a whole lot we do with trauma. It's the coolest thing to talk about, and it's the most like gnarly thing to look at.
Yeah,
and it's the stuff that you want to like see on TV. But like the treatments are pretty boring because we're not really treating an injury. Okay, like even with hemorrhage, we'll talk about hemorrhage in another podcast. But like even with hemorrhage, like you just like cover up the yucky thing and you're helping the body do its own thing. You're helping the body heal, helping it clot. You just if it looks yucky, you cover it up. You hold pressure, right? It's not a whole lot. It's not like we're intubating or we're doing something fancy to like fix it, right? We're not giving a medicine to fix it. With injuries, especially orthopedic injuries, our job isn't really to fix anything. Fixing happens in the surgical suite or it happens over time from your own body healing itself. Right. Like we can give medications that can progress the healing, like anti-inflammatories and things like that, but that's long term. But there's no medication or treatment that's going to snap someone's bone back together or put it back together or do anything like that.
We should come up with that.
Yeah. Yes. Hey, tell you what, if you have an idea, I will invest all my money in it because that would be great. So our job is basically to not make the problem worse.
Yeah.
Our job is to just make sure that that injury doesn't get worse. Yeah. So in terms of a sports injury, most sports injuries, it's going to be immobilization. 100% we're immobilizing the patient, or at least where the injury site is.
Yeah, for sure.
And then we're transporting. And we do supportive care. Remember that these patients may have internal bleeding. They may have major shock symptoms, depending on they may have pain level. So, I mean, we're going to treat the pain. We'll treat the pain with a analgesic. We might need to support them with shock, keep them warm if they start, shunting blood to the area or they have interior blood that they're losing. So we're going to do shock treatment. We're going to do those basic treatments. But in terms of the injury itself, all that we're really doing is covering it up and making sure it doesn't move and get worse.
Correct.
Right? And what I've always been taught is, and this is a nice little street cheat, is that if you injure a long bone, you want to splint the joint above and below that.
Yeah.
And if you injure a joint, you want to splint the long bone above and below that.
Correct.
So if I hurt my radius ulna, I want to make sure that I can't move my elbow and I can't move my wrist. Right?
Yep.
That's the whole point. Yep. Because if I can move the things that are surrounding it, I'm moving it through accessory muscles and I could cause more damage.
Making it worse.
And what's interesting is it doesn't matter if you have an open fracture, doesn't matter if you have an open injury, a closed injury, whether it's a compound fracture or it's like comminuated where it's in pieces. It doesn't matter if it's a sprain or a strain. It doesn't really matter to us. All we care about is, hey, don't move that thing anymore because it's going to get worse.
Stop the movement.
Right?
Yeah.
So we use a number of things to splint, but like common stuff that we use, especially for like ankles and hands, we'll just use pillows. We'll literally just take a pillow, surround it, and duct tape it. And a lot of people are like, well, that doesn't sound fancy or look like something that would be cool on Chicago Fire. But it does a good job of it because what does? It bulks around it. You can't move it.
Stop moving
and
it.
it's padded all the voids in that area, right? So we check for CSM, so sensory, motor, and what am I missing? Circulation, right? So we'll check to make sure that there's good blood flow, that we can get a pulse, and that they can feel and move.
Yep, very important.
Once they do that, that would be distal to the wound, right? Downstream. We want to make sure that they're good to go. And then we'll go ahead and splint that and we'll immobilize. So checking all the boxes or
checking all the boxes,
anything special you do?
No, it pretty much hit all the major points. We just splinting wise, since you mentioned your pillow technique, we always have just a bag of air splints.
Yeah.
Where if something does happen, we have the piece for the right limb or whatever it may be. And that's how we just immobilize with an air splint.
Yeah.
Which makes it easy. Fills the gaps, like you said.
Yeah. And that's the big thing is like the joint above and below, the bone above and below, and then make sure that you pad the voids, just meaning that if there's gaps or spaces in between the splint area and the limb or whatever you're splinting, you want to move it. Obviously, talking about spinal injuries, like you mentioned earlier, it's a little difficult to splint the entire body, right? So
a little tough.
The biggest thing we worry about is C-spine. So we're always told to just grab the bony prominences of the head, C-collar them and keep their head still. A lot of that is kind of coaching them on scene to be like, hey, don't look this way or that way, obviously, until we can get that. So one person's kind of just in charge of that head. That's what we'll do right away. We used to be big about backboarding. I don't know where are you guys at with backboarding?
Like splint, like full on.
Do you ever put people on backboards, do the whole deal? Or no?
Oh yeah, that's how we're taught.
We're getting away from it because we're finding that when you transport someone on a backboard, it janks up their spine, and you also can't pad the voids because you have a rounded, your spine kind of protrudes, you have a rounded back, right? So like for the longest time, like you'll still be trained in classes to backboard someone standing up and laying down.
For you guys?
Yeah, but now we mainly use it as a transfer device. So we'll actually use our stretcher to just like splint it. The stretcher has cushions on it. It fills the voids already, and we'll just keep them still.
Immobilize the spine, like the C-spine or whatever.
Yeah.
Do you still do that?
We'll use the backboard to get them to the stretcher, and then we'll dump them off the backboard safely by rolling them, and then they'll rest on the stretcher. Because as long as the spine's not moving, we're good. Yeah. You know what I mean?
Right.
So that's kind of like what we've been leaning towards because we were realizing there's issues with the backboards.
I believe it.
So there you go. A little cross training for you. In terms of if I'm responding to a field or a court or I don't know what else is there in sports, a ring. No, a ring. I'm thinking like a boxing ring or a rink. Yep.
Court, field, pool, mats, gymnastics.
The mountains, rock climbing. Anyway, we do have to consider some environmental factors, right? So just remember that these athletic trainers that you'll be working alongside are more familiar with that environment than you are. Okay, so we need to heavily rely on ATs all the time to help us out in these certain situations. So if you're covering a game or a match or an event, like know who your ATs are and know what your little process of responding to an acute emergency is going to be. Because an AT, Chris is going to be involved with you if you're on the court and there's an issue at Mizzou in the next few years. Yeah. This podcast is going to be timeless. So when you listen to it 5 years from now, I don't know where you'd be. Maybe you'll be president. Who knows?
Sure.
Of ATs. It's probably a thing.
It is a thing.
So anyway, we want to rely on you. We want to ask you questions and beforehand, hopefully, have a decent working relationship with you.
Yeah.
Things that we're told a lot about are like pad removal and equipment removal. I know you do basketball, so there's not a whole lot of pads and equipment, but in terms of like football or hockey or things like that, typically the route is that we won't remove even the helmet unless it is interrupting the airway. So if it's interrupting the airway, we'll cut the shit out of it.
Yep. And I think that's kind of what's being taught now. Yeah. With football, hockey, college hockey at least, you will remove the face mask usually. So there will be, somebody should have a drill on site where you just unscrew the things and you can remove the actual bars of the mask, whatever, but keep the helmet on. That way you're not moving the spine. That's if airways are obstructed and you need to do CPR and all that stuff.
Right.
But yeah, we kind of have been taught the same thing. Okay. Just kind of immobilize as you can with the helmet still on, less movement.
And then you would be the guy that I talk to if I need to remove pads for some reason because there's some sort of compromise. Yep. So even like with football pad, if you got to penetrate an object, I need to get to something. You're cutting
everything off.
We're cutting things off, but we're going to probably be deferring to you because you're familiar with the systems on how to remove them, and you're familiar with the systems on how we'll kind of collaborate on like, hey, we'll hold C-spine, walk us through. Because I wouldn't know. I wouldn't be like, get the drill. I don't have a drill in my ambulance ready to go for football helmets, right?
So if there's a C-spine injury on the field, court, whatever it may be, usually the athletic trainer is probably the first one out there, which puts them in charge of the head, the spine, all of that, which puts them in charge of the whole situation.
Operation, yep. We operate the same way.
Yep.
Head guy's in charge.
So, but if pads need to be removed, it's at that point you're just getting them off any way you can. So cutting, whatever. So if somebody has scissors on them, just get them off because we're in that sort of emergency.
I got you.
The guy in charge of the head, as you probably are well aware, is more in charge of making sure EMS is either on site, AED is needed, movement whenever it needs to be done, lifting, all that stuff.
Gotcha. Cool. Yeah, I think that we underestimate, because we cover, when I worked private EMS, we covered sports events all the time. I'll tell you right now, I didn't know who the hell the ATs were. And like, had something happened, I think it would have been a little bit of a mess. Like, it's important to know, like, typically is there always an assigned medic or transporting like agency, like handing out of the basketball? Like, do you guys have like a private ambulance company?
No, I think we have a university hospital on campus. So we kind of just use them, which makes it easy for us.
That's awesome.
Obviously, it's not going to be the same people every time.
Yeah, but you have assigned
same company. They always are in the same spot. Like we know, we set them up in the same spot. They know the same spot. What's becoming more kind of prevalent in sports is what's called a medical timeout. And it's kind of where the AT, the doctors, if they're on site, the opposing AT, if they're traveling one, and then EMS will kind of all meet together, 30, 20 minutes before the game, and just kind of go over the basics of what needs to be done, what happens if this happens,
They call it a timeout, though?
Call it a medical
it sounds
timeout.
Negative.
Oh, the timeout is like you're taking a break.
Call it like a powwow or something. Timeout makes it sound like someone's in trouble.
No, because like in sports, a timeout is kind of when you take a break and everybody comes together and you kind of huddle up. So it's just a medical timeout.
Medical timeout. That's good. So you're collaborating a little bit.
Yeah, basically.
That works.
Make sure everybody's on the same page.
Okay. Last thing I want to cover today, we covered kind of EMS and the AT working together, the environment factors. Oh, one thing too is that you're a huge resource when it comes to the history of the patient too. Like, because you are so familiar, at least like their orthopedic, you might not know if they have like AIDS or something, but you might know. I guess you might know.
They kind of have to disclose basically every sort of medical.
So Chris would be the guy to talk to too if you're trying to gather patient history and things like that. Like you can get a lot of the background. So again, huge resource on the field or at the event. So pay attention. Last thing I want to talk about, because we just don't know anything about this in EMS, but like in terms of treatment, like more longer term treatment. So we'll immobilize, we'll cool it to stop inflammation. But you have a lot of resources available to you for long-term treatment once the acute injury is, the emergency is passed. So
so I would say that's probably my biggest piece of my profession is the treatment. Obviously, injuries occur, whether it's acute, chronic, nagging things, whatever it may be. Treatment on a daily basis is almost half of what I do. And we have, luckily for me at the University of Missouri, we have lots of resources at my disposal. So, I mean, we have heat therapy, we have cold therapy, which ranges from a hot tub to a hot pack to like back braces that do heating and vibration.
Ice baths.
Cold therapy, ice baths, ice bags.
Did I ever tell you about my ice bath experience?
No, you got in an ice bath?
I ran a marathon. So my first marathon, everyone told me you got to take an ice bath. That's where it's going to help so much because you just feel like all your joints feel ground to a powder.
I don't know why you'd ever want to do that.
So I was like, yeah, I'll do an ice bath. I didn't know that it had to be like a certain temperature. So I go upstairs and I just dumped a bunch of giant bags of ice in a tub.
Frozen almost.
And then I got in and I made it to like maybe my upper thigh and then was like, this is the worst pain I've ever felt in my life because it's so cold, and I was done. And then you told me later, I don't know if you remember me telling you that happened, but you told me later, you're like, no, it has to be like a certain amount of degrees. I was like, that was way colder than that. I was like, sub-zero.
We keep ours at like 40, somewhere between 45 and 50.
Yeah, mine was well below that.
Yeah.
Because it was just a bunch of ice. How was I supposed to do that, though? I don't have like a temperature gauge in my bathtub.
Do you have a meat thermometer? I'm just kidding.
Yeah, I think it's the same. I don't think it'll go in that direction. So anyway, cool. So ice baths.
Cool. Yep.
You got lasers.
We do. We have laser therapy.
You get electricity.
We have electrotherapy. Yep. Stim
do
machines.
You do the
10
needling
units.
thing?
I don't do the dry needling yet.
Oh,
I will be getting certified this summer.
I got dry needled for my ankle injuries after my marathons, and it is.
Yeah, it's
they dry needled me, and then they introduced electric shock into the dry needle, and then they spasmed my
deep muscle.
That wasn't
electrotherapy.
Fun. But that helps.
Yeah, so
reconnect that like neurologically, right?
Neurologically, yep. And it kind of, in some cases, like electrotherapy can be used to kind of block those pain signals. And
that's cool. I one time too was interning at a PT place, and they had like a shock machine on the guy's shoulder, and then they accidentally malfunctioned and went up to like the top, and he just started screaming, and no one knew what to do. And then I reached and unplugged it, and they were like, "Oh, that was smart." Wow. Yeah, it was pretty dumb response. I won't share where it was. It had nothing to do with you or anyone you know, but
that's
it was kind of. So then you guys will also do scraping.
Yeah, A-stim, which is what it's called, or high stim, whatever you want to call it. Grastins is another term for it. I was told like you have inflammation of the fibers, and then scraping basically smooths the fibers back out to realign almost. Yeah, so kind of like adhesions or inflammation, scar tissue. You kind of scrape them so that they kind of break up, and then it kind of heals or realigns, like you were saying, back into what it's supposed to be.
And then I think we were gonna cover this. I forgot to mention it, but there's like the four degrees of an injury, right? Or the four, not degrees, but the phase. No, inflammation,
It's
reparative, remodeling, and maturation.
The
4 stages of an injury, right?
Well, 4, 3. Sure. Yeah.
I guess, are you saying remodeling and maturation is the same thing?
Sometimes they're thrown together.
Okay,
that's
gotcha.
all I was saying.
So inflammation phase, that's what I'll be dealing with.
Yes, more often
inflamed
than not.
acute injury.
Yep.
So then once you've kind of calmed down the inflammation, it now starts to repair.
Yep. Starts to get all that inflammation out.
Right. So the reason and you guys should know this, but the reason that we have an inflammatory response is to bring fluid to that area, bring cells that can then eat the yucky stuff, start repairing it. It's necessary.
Yeah, a
so
lot of people,
swelling is good.
Yeah, a lot of people think swelling, inflammation is bad when in actuality it's a good thing. Needs to happen. It's part of the process.
If it's interrupting your ability to live your life or even exercise in terms of like core exercises to build strength, you might be getting anti-inflammatories to take care of that, to control the pain.
Yeah, long-term inflammation is not necessarily good.
Right. But that acute inflammation you want.
Yeah, you have to have it.
So we'll do ice and stuff like that to tone it down to reduce the pain. But now I'm going to make you say the controversial thing. All right. So what is it? Do we do rice or not? So typically we would normally
put me on the spot.
So rice is
rest.
Rest. Ice.
Compression.
Elevation. And elevation. Those are like our go-to when it comes to an injury.
But
it's controversial now because science is changing.
Controversial.
Because if I know anything about science, it changes all the time.
No, it's just what everybody's known for decades.
Right.
And as we've learned more about the body, some people seem to think that ice isn't necessarily the go-to treatment for inflammation.
Right.
We just stated that inflammation is good.
Yeah.
Ice does what?
Reduces inflammation.
And
it makes things
constricts.
Cold.
Yeah, it constricts the blood vessels.
Right.
So you're either stopping the inflammation from coming or you are trapping the inflammation in the injury.
You're slowing down blood flow, slows down the healing process then. So
what has kind of been gaining movement is heat and just general movement, which acts as its own kind of pump.
Right. But again, there's so many nuances with it because it depends on the injury, it depends on the individual, it depends on where in the injury process they are, because that acute inflammation is good, but like you said, long term, you don't want to bog down the joint. So there's a lot of So currently in development, there's a lot of opinions on it.
Yeah, we'll go with that.
What should I do? Should I alternate heat and cold if I'm hurting? When do they tell? Why do they tell sometimes to alternate?
Because it acts as a pump. So cold vasoconstricts, heat vasodilates.
Oh, that makes a lot of sense.
Which acts as a pump and flushes
out,
inflammation
but keeps
in
blood
or
flow
inflammation
going
out. Yeah.
Interesting.
It's called contrast therapy.
Contrast therapy. People, you heard it here first.
Not
Chris
really.
just invented it. Cool. Any questions you have for me as a paramedic? He's like, I don't care.
I don't know. I mean, have you had much experience with ATs? And if so, has it been good?
As I practice, yes. When I was a field medic. So I did that field medic stuff
in the military?
as like a side gig. No, not on the field medic. I worked with football. And it was just like, this was like a side gig. This is like, I was like in between jobs. I was also still in school, but they were like, okay, here you go. Like, take this job. They paid me a ridiculous amount an hour to like watch these. It was little kids play football. It was supposed to be flag football. I'll tell you right now.
Turn out to be
flag football. 8 flag football. All right. There was contact every 20 seconds. Worst thing I had was I had to call 911. I was actually in Madison Heights, which is what's funny, which is where I work now. But I had to call the fire department because I came onto the field and like everyone broke from this huddle and this kid was just screaming and writhing on the ground and he kept yelling like, I'm sorry, coach. And I was like, dude,
didn't want to let his team down.
Yeah. I was like, this is some cultish stuff going on right now. But anyway, me and the AT just kind of figured it out together. Like I would bring the little backpack of like my medic supplies and then he brought stuff. And then we just, like you said, he took C-spine and then I just sort of deferred to him.
Yeah.
And that was the best thing to do. But it was all positive experiences. So
that's good.
Yeah. Have you had negative experiences
with
paramedics?
Never.
So, good.
Besides being your friend. But no.
Oh.
I'm just kidding.
No, but I think that's one thing that we try to push all the time on this podcast and in our prep program and our company as a whole, like collaborating with other.
It's necessary.
Yeah, it's like it is we have to have more of a holistic approach to medicine in general. Like if you get stuck in your box of I'm a medic, I don't need to talk to nurses, I don't need to talk to ATs, I don't need to talk to docs, I just do my medic stuff. You're going to be a very closed-minded medic. You're not going to get much done. Yeah. So this is good. This has been positive. Thank you for your time.
So. Thanks for having me.
All right. That's all we have for today. Remember, guardiantestprep.com. Check it out. 15 hours of video content. You guys can hear me and my brother goof off and teach you about all kinds of topics, everything that you can need to learn in EMT, AEMT, or medic. Lots of test questions, lots of practice. There's a workbook. It's over 1,000 pages, things to work through. Will very much help you prepare for your NREMT or get through your class, or just refresh you if you need new information. You can check out this episode in about a month on Guardian CME to earn a CAPC credit for it. And thank you, Chris. Hopefully we'll have you back soon.
Yeah, definitely.
All right, take care. Stay sweet.
Hey guys, thanks so much for taking a listen. If you are studying for the National Registry exam, we're here to help. We have a National Registry prep program to help you pass that exam. Check us out at guardiantestprep.com. If you'd like continuing education credits for listening to our podcast or watching this on YouTube, follow us at guardiancme.com. 100% free CAPC credits. No matter what state or country you're in, we're here to help. So again, we thank you so much for listening. We hope you have a wonderful week.